whilst you're presenting. It just helps so that we can minimize any background noise. Okay, I think we should start. So we got about 64 people, and I know that we're expecting a few more people to join us this morning, so they'll probably be joining as we go. But I think we'll get on and start because we've got a packed agenda, a lot of things to learn. I'll be learning a lot as well. But I think we just want to, as I always say, plug along. So we've all know, I think from most of us now are so used to using Teams. I won't go into detail, but please feel free to use the chat box. You put, your questions or comments in there. We'll try as much as possible at the end of this webinar in the next couple of days is to actually collect as much of the key things and themes that come out and actually put a document together. So please utilize, and also we've got a few of our PLOG members in the background. I'll just put a few names. We got Caroline, we got Lean, we got Alison, I got Debbie. They're all in the background helping to monitor the chat box. So they might be able to answer some of the questions as people are coming through in the chat box and supporting that. And they're also part of that presentation. Okay. So as you can see, I just imagine we did send the agenda and attach it to the Eventbrite. So I imagine a few people have managed to see it, and we also circulated it as well yesterday, just as a reminder. So I hope a few people have managed to see that. But just a reminder of the agenda, we're going to have, I didn't introduce myself, so apologies. So my name is Tendai Nzirawa, and I'm the chair for the Pediatric Penn London Oxygen Group. Even though it was started as a focus for London, but it has really, we've now spread out into the whole of England and trying to support and implement any change to standardize our practice for pediatric home oxygen. So I'll be also chairing today as webinar. So we're going to have a presentation about weaning from Dr. Hazel. Unfortunately, she can't join us today. But however, we've got her presentation and her recording that we'll be sharing, which is very interesting. We're going to touch a little bit on RS research from our perspectives as PLOG. What we think, should we be worried, is, as you can see, the topic. There's going to be a presentation from as well, Moni, who's the operational lead for the London Oxygen Service. And we've been working with Moni for years in things that everything PLOG. And she's been very supportive. So we'll be having that insight and that discussion as well from her regarding what it means regarding pediatric and commissioning and home oxygen. Touch a bit about risk assessment, the school bundle. I've got somebody saying they can't hear. Can you all hear me? I saw somebody on the, okay, that's fine. So the school bundle, home oxygen weaning as well, the pediatric guidance, the transition from pediatric to adult, and hopefully we'll have a couple of minutes at the end as well to actually just facilitate any other key things that you probably be saying, I really want to have the opportunity to know about this or to have the support about this. So we are hoping, it's a packed agenda. We will try and pick up one or two questions probably after each presentation. But if time is not on our side, we'll move on so that we can hopefully pick up some of those questions at the end. So you might be asking yourself, what's been happening with PLOG? So PLOG, as you are aware, started about 4 years ago. And one of the biggest reasons, I really would like to appreciate Caroline Locke. Most of you know her. And she actually was one of the co-founders of PLOG. So we worked together at the beginning, as she also was the driving force to actually say there is a problem regarding home oxygen in pediatric. And we came together, and we, as part of the co-founders, I think Debbie was part of that, and Lean. And we actually came together with a few other people that unfortunately are no longer PLOG members, but actually were the driving force to where PLOG is today. And part of the challenges that people were finding was about the variation regarding pediatric home oxygen, just that pathways of knowing, how do you support parents? How do you get the competencies right for staff and things like that? And it just started as a small project, but as you can see, it has become something bigger. So what has been happening? We've had a couple of study days. We've had probably about 7 to 8 study days in the past 4 years, and most of them have attended at least by between 40 to 50 people at each study day. We've had also small little workshops that PLOG members have gone into hospitals, have done one-to-ones with other people just to facilitate sharing that information. We've had people representing PLOG from every corner, not only London. We've had to share PLOG. We've had Joe, who's also on our call today, sharing PLOG in Southwest England. We've had people also sharing it in different platforms, Birmingham and things like that. In Essex as well, we did our last study day there. So we've now reviewed the discharge bundle, which you probably have noticed on our website. We'll get our colleagues to probably put the website link as well in the chat box. So that's now updated, that's been reviewed, and we've now uploaded it onto the website. We've now created guidance document for weaning of oxygen, and that will be spoken about today. And as well, the guidance for school nurse, school oxygen transition. As you can see, there's been lots of work happening, especially in the last 12 to 18 months. We are progressing on other work. As you can see, the pediatric WASA documents, that's some work we're doing with Moni and the London Clinical Oxygen Network, looking at smoking as well, and scoping about oxygen, palliative care, sickle cell, and other things. So you will probably be hearing more about PLOG in the near future. So I won't take so much of your time. We're going to go into the presentation by Dr. Hazel Evans. And I hope you got your notepads with you, because there's so much to learn. She's done lots of work and she's still doing lots of work. So we are a close link with Dr. Hazel. We've done some projects as well under PLOG with her. So I'll go on the presentation.
Good morning, everybody. I'd like to thank the organisers for asking me to give this talk, and I'm sorry that I can't be with you this morning. I'm going to give you a brief overview of using oximetry to measure hypoxia in preterm and term infants.
Oh, sorry, the sound seemed to have gone. Apologies, just some technical issues with the sound.
Good morning, everybody. I'd like to thank the organisers for asking me to give this talk, and I'm sorry that I can't be with you this morning. I'm going to give you a brief overview of using oximetry to measure hypoxia in preterm and term infants. Firstly, I want to talk about the impact of different saturation monitor settings on data output, and then hopefully develop a little bit of an understanding on how we use normal saturation parameters in healthy infants to provide information for how we prescribe oxygen and wean that in infants with bronchopulmonary dysplasia. And these infants are becoming a more regular occurrence in our clinics. That's because preterm survival rates have improved, and about a third of babies born under 32 weeks develop BPD, and within the UK that accounts for about 7,000 babies a year. And they also form a really big group of babies that are children that are in oxygen at home. About 2/3 of children in oxygen at home are babies with bronchopulmonary dysplasia. And these babies do have a significant morbidity. They have an increased healthcare utilisation, with about half of them being rehospitalised in the first year of life. And if you look at it from a health economic basis, these babies have sort of double the costs in terms of healthcare costs when compared to their counterparts that aren't born prematurely or don't have bronchopulmonary dysplasia. And so when we're trying to decide whether to send a baby home in oxygen or not, it's important that we try and review the evidence that is available. And there's a number of guidelines that are published that we tend to refer to. And these span a decade, starting with the British Thoracic Society guidelines in 2009, and the most recent guidelines published by the American Thoracic Society in 2018. But the sad fact about those guidelines is that all the statements are based on a stark lack of evidence. And Ian Balfour-Lynn wrote in the Lancet really about how disappointing it was that there was a striking lack of empirical evidence regarding both the implementation, the monitoring, and discontinuation of supplemental oxygen therapy. And the only recommendation that really came out of the latest American Thoracic Society guidance was that oxygen should be prescribed for chronic hypoxemia. So how are we defining chronic hypoxemia? Well, both the ATS and the BTS guidelines define a cut-off of 5% of the recording time with saturations below 90%. And the British Thoracic Guidelines also state that the mean saturation should be above 92%, and none of these recommendations are evidence-based. So what happens in the UK? Well, we were aware that there seemed to be a wide spectrum of practice, so we had a trainee working with me, and we worked with the Paediatric London Oxygen Group to develop a survey that was circulated around to neonatal units around the UK, and we had responses from 44 units. And interestingly, you can see there's a wide spectrum around decisions around initiation of oxygen, but the main criteria for decisions around oxygen prescribing at discharge was based on mean saturations and the percentage of time below 90%, which you would expect because those are the criteria from the British Thoracic Guidelines. But interestingly, these criteria were really only used by 50% of units, and the saturation thresholds ranged very widely from between 92 to 97%. And also the percentage of time with saturations below 90 also had a wide range of between 4 to 20%. And interestingly, although several units commented that they followed the BTS guidelines, when you asked them what they actually did, they weren't implementing oxygen as per those guidelines in about 50% of cases. What about weaning of oxygen? Again, the same criteria used in about 50% of units, and a wide range of other factors are also incorporated by other units. And then we thought it was important to think about technical considerations about what people knew about the oximeters they were using and the measurements that they were making. And one of the things that we felt was important to understand was how long the sleep study needed to be regarded as providing useful information to prescribe oxygen. And again, there was a huge range. About 50% of units felt that they needed 6 hours of data, but there was anything from 2 hours to people not really being sure. And finally, we asked about technical considerations within the oximeter itself, and that was based on the averaging time of the oximeter, and most people really didn't know what the averaging time of the oximeter was, and I'll come on to the importance of that in a minute. So what does it matter? Do these technical considerations matter? And increasingly, oximeters are used which are able to extract motion and have very short averaging times, and these are certainly being incorporated nationally in paediatric sleep units and are becoming more widely available. A motion artifact is really important because, particularly in wriggly babies and young children, and one of the reasons it's really important, obviously, is because it removes artifacts secondary to motion. And you can see in this slide, this was a patients that acted as their own control, so they had oximeters on both hands, and they were advised to move their hand around on one hand and then keep their hand still on the other hand. And what they found was if you had an induced hypoxia and you had a hand in motion, then some oximeters were better able to remove the artifact as a result of the motion and detect the true hypoxia. You can see that on the blue arrow in the graph below, whereas other oximeters in this slide with the blue arrows were unable to accurately pick up the genuine desaturation, which is identified with the very narrow dotted line, and so you got a much more wobble effect. You didn't get to see the nadir of the desaturation, and the desaturation appeared to go on for longer, so it wasn't accurately identifying that true desaturation. The other factor that is becoming increasingly recognised as being important, particularly in young babies, is averaging times. Now, what that means is an oximeter takes regular readings of saturations, but what it does is it reads back over a set period of time and averages out those readings to then give you a number on the screen. So if you set an averaging time at 16 seconds, what the oximeter will do, it will go back over the previous 16 seconds of values that it's recorded on a beat by beat recording, and then average that number out. And if you reduce the averaging time, then obviously that's over a shorter period. And what happens in babies, as you've all seen babies, they take lots of very rapid breaths and then they have pauses. And you can see in this slide here, this is a cardiorespiratory sleep study from an infant, and in the purple box, you can see that there is an absence of flow, which represents a short pause in breathing, and that is at most 5 seconds in duration. And you can tell that's 5 seconds in duration because the vertical bars represent a 10-second epoch. And then this short pause in breathing is followed by a very brief desaturation, which is only maybe 3 or 4 seconds long. When we think about averaging time, it's really important, because if we set a long averaging time of 16 seconds between the two red arrows, if lots of little dips in saturation, these are completely blunted out, and you get that hashed grey line, and you get a slightly lowering of your baseline oxygen saturation, and you miss the genuine desaturation as a result of that short pause in breathing. And what we found from a study that we did in healthy detect periods of active sleep or REM sleep where babies are more vulnerable to desaturation, and in the red line at the top you can see several small desaturations, but presumably due to short pauses in breathing. So does it matter? Do these little pauses in breathing matter? Well, the honest answer is we don't know. What we do know is that babies that seem to have more brief desaturation events are associated with an increased healthcare utilisation in the first 2 years of life. We know from rat studies that episodes of intermittent hypoxia are associated with impaired growth, certainly in the first month of life, which probably equates in human terms to about the first 2 to 3 years of life. And we also know that if you look at cerebral perfusion and link them to these central apneas, that cerebral perfusion is impacted by these very brief central apneas, and that's actually most marked at around 5 to 6 months of age, when presumably the brain is becoming more metabolically active with growth. But might oxygen be harmful? Well, there certainly are concerns about that and using it unnecessarily. There's the best data we have around that was actually a retrospective cohort study, which was undertaken in the States, where babies were a clinical decision was made as to whether to discharge babies home in oxygen, and some went home in oxygen and some went home without oxygen, and then they were matched for the severity of lung disease. And what they actually found was that the babies that had gone home in oxygen seemed to have more hospitalizations for respiratory illness, they seemed to end up on more medication, and they seem to be more technology dependent. Now, there may be a lot of confounding factors with that, in that if you send a baby home with oxygen, they may have more regular review, there may be more parental anxiety, so they seek healthcare help more regularly. But it's an important observation, and the authors of that paper are now proceeding with a randomized controlled trial with set criteria for sending babies home with or without oxygen, and they're looking at respiratory and growth outcomes at 6 months of age as part of that RCT. So when we are thinking about whether to discharge babies home in oxygen, we do need to strike a careful balance between our knowledge that young healthy infants have brief oxygen desaturations. Oxygen's a drug, so that has risks of its own in the home environment, and we need to try and avoid the risks of intermittent hypoxia, but also think about there might be potential effects of hyperoxia as well that we need to avoid. So when we think about what we're going to do about prescribing oxygen, it's important to consider the normal data. Now, there's been studies performed in healthy infants from 35 weeks gestation. I think what's really important to note is that actually mean saturations in these children using these new generation oximeters are very similar to those in older children. So we expect mean saturations to be sort of 96% plus. When we look at desaturation indices, the 3% desaturation indices, which is a drop of oxygen saturation of 3% from baseline with a pause, so going from 95% to 92%, etc. Actually, these babies experience a lot of these, so it's not unusual for a baby at term to be having 30 to 40 little dips in oxygen saturation per hour, averaged over the whole night. And also, these babies do not spend long periods of time with saturations below 90%. It's usually less than 1%. And what about the extreme preterm group? Well, the data is quite limited, and some of these babies that were studied had in these studies were actually in oxygen. There's a couple of babies actually on CPAP. So in terms of generalizing the data, it's very difficult. There are a lot of confounding variables. But what we do know is that these babies seem to have more oxygen desaturations than the healthy preterm cohort at term. So we've pulled this data together, and we've recently published a paper where we're making the following recommendations around criteria for initiation and weaning oxygen. We believe that mean saturation should be at least 93% and arguably should be a bit higher based on the data that's available. Babies should not spend long periods of time with saturations below 90%. And we've put in some criteria for age-dependent 3% oxygen desaturation indices, because these do change rapidly as babies mature and develop. And one of the other factors which I know that the London Oxygen Group have been very keen on developing is structured weaning, and we know that's associated with improved outcomes, it's associated with pulmonary hypertension, it's associated with a more rapid discontinuation of oxygen without adverse respiratory outcomes, and if you can get babies out of oxygen faster, that is associated with improved parental quality of life and reduced parental anxiety. And so this is the pathway that we follow, that again we've recently published. And what we do prior to discharge is we perform overnight pulse oximetry to determine the optimal flow rate for discharging babies home in oxygen. And we also perform an echocardiogram to look for pulmonary hypertension so that that can be treated accordingly. It's important that oximetry is repeated every 3 to 5 weeks so that oxygen can be weaned in an appropriate manner and babies don't go home and stay in oxygen for months on end. And what we do when we're doing our weaning program, we do the first night in families take them onto home for 2 nights with the alarms on, and we do the first night in their currently prescribed amount of oxygen and the next night in 0.1 litre per minute of oxygen lower. Once babies reach a weight of 2.5 kilograms, it's perfectly adequate to wean in increments of 0.1 litres per minute, because they entrain a lot of air, and so the amount of oxygen at the back of the pharynx is diluted significantly by room air, so you can wean at a minimum of 0.1 litres per minute. Once we get babies down to 0.1 litres per minute overnight, we then do daytime weaning, and I know that your group have developed a very clear weaning plan for daytime weaning every few days, just increasing the amount of time in air and having community nurses or neonatal home care nurses visiting at the end of that period of time in air to check the baby's okay. It's important that that daytime wean happens during periods of wakefulness and feeding, as that's a time when there's most demands on the respiratory system. And then once the baby's in air during the day, we then do a nighttime wean. And again, we do a 2-night study, night 1 in 0.1 litres per minute and night 2 in air. And once all the targets have been met, we discontinue oxygen. We do feel that any baby that's still in oxygen at the age of a year should probably be seen in the paediatric respiratory service, just to check there aren't any other comorbidities that are affecting ongoing oxygen dependency. And this is just an example of one of our babies that we've studied. In the top graph, you can see in the blue line, you can see nice cycling between quiet and active sleep. And during periods of active sleep, there's very subtle dips in oxygen saturation, but there aren't any significant dips in oxygen saturation. But when the baby was put in air, in the bottom graph, you can see that these dips in oxygen saturation are much more apparent. And so the recommendation of this study was that the baby stayed in 0.1 litres of oxygen for another month, and then we did a follow-up study. So in summary, I hope I've managed to sort of convince you that technological considerations are important when we interpret sleep studies in infants, as they do impact on data output. It's really important that when you're prescribing and weaning oxygen, that you follow the reference ranges that are appropriate for the oximeter you're using and age dependent. And a structured weaning program can really help with reductions in pulmonary hypertension and improved quality of life, alongside a more rapid wean out of oxygen. So thank you very much for your attention, and I hope you enjoy the rest of your morning.
So thank you very much. That was really a foundation of exactly the things that we're highlighting about, just having that collaboration with Dr. Hazel, and some of the evidence why as well we've done the weaning guidance that will be, discussed and shared later on. I know that there's a few people that are probably having issues joining the link because I've seen some messages, but hopefully we'll get people that's resolved. I'll get Caroline as well to keep an eye and Lynn on any messages coming through. Yeah, they're on the PLOG website. Thank you. So we'll move on to the next one. So as I said earlier on, we're going to talk about, hopefully, RSV surge from our perspective as PLOG. As we know that there's different discussions happening right now, nationally, regionally, locally, regarding RSV surge. So I'm just going to just touch a bit on that. So as we know, regarding RSV, it's something that's not new to any person who's working within children and neonates, world, because RSV has been there for years, and we know that we've been dealing with that for the past couple of years. Especially the Green Book actually highlights the guidance that during the winter season between October and February, it's now I think even up to March, we still have high RSV rates for especially our less than 2-year-olds, and sometimes we get a few less than 5-year-olds. So it recommends that we should be actually identifying these children early. We should be able to support them so that we can make sure that they are immunized. So we are giving them the RSV vaccination or the immunization every 28 days, starting from September. So this is supposed to help to reduce that infection in the lower respiratory infections. So you should, as I said, should we be worried? Yes, we should, because we know that for our age group, especially children who are less than 5 years old, that RSV is much more worse for them than actually our seasonal flu in the first, couple of years. And the rate, this is a public health, as you can see, this chart is a public health chart. And it also, there was some research done in Oxford, and it says around 30,000 children under the age of 5 this year in 2021 are estimated to be hospitalized, with RSV infection. And public health is actually having this modeling, and they are assuming that there will be between 30 to 50 more cases this year that they have children that will be hospitalized with the RSV. So yes, we should be worried because that's a bigger number than our expected. We're going to expect a double of the pediatric intensive care beds. We're going to expect an increase of critical care, sick children, and this is mostly our vulnerable group. I keep on highlighting the less than 3-year-olds. Because if we don't really capture that group, and those are the ones, as you saw Dr. Hazel's presentation, they're the ones that tend to require home oxygen. They're the ones that even if they do win off oxygen while they're still in the pediatric or neonatal unit, sometimes do have a little bit of respiratory problems on and off in the community. And we've got as well the other comorbidities, the cardiac children, the ones that are also waiting for cardiac surgery. We're talking about as well your trisomy 21 children and other comorbidities. And we try and encourage that these children, if we can, identify them early and be able to support them. So what do we know? So we know that there's been some key updates in the past couple of months. So in October 2020, there was publication about the guidance. So we know that there was guidance that came out to actually support, because they expanded who should be actually having the RSV immunization. So infants that were born less than 34 weeks and diagnosed with with chronic lung disease, and those that are discharged from hospital on or after the 1st of January, that was in 2020. So far, as I've checked, this hasn't changed at all. So we're still going to use this guidance. So what else has changed? So we know that the company that we were all probably using, which is the only company that we are using because they're the only suppliers before for our RSV vaccinations, was LV. And now the transition has now been completed. AstraZeneca has taken over. And the history is AstraZeneca always owned the rights of, the RSV vaccinations. However, that was given to LV as per contract, and now they've taken it back. So that has just happened on the 1st of July, 2021. So some of you I know haven't actually known, who are you making contact? Where is your supplies coming? How soon are they coming? Because especially with the surge, we need to start planning ahead. We used to start our RSV clinics in September. And I think the anticipation is we need to start thinking ahead, that how soon can we start them, than to wait until a few more children start getting hospitalized. So I think early planning will be key. As you know, regarding the RSV, so we know that the incubation period is within the period of 2 to 8 days. The symptoms then come up and we see them up to 3 weeks. That's why parents will call you quite often if you're in the community, or if you're respiratory nurse or you're a clinician, to say, baby's still not feeling well, they're still coughing, or they're still under the weather. As we know, this can last up to 3 weeks. And we know that at least 3.4 million of hospital admissions are actually every year in winter for our less than 2-year-olds are actually based on RSV infection. That's just a picture of some lungs, just to show you how the preterm lungs are so different to our term lungs and why those groups are most vulnerable. So why is this really important? As you can see, the most objective for us as a PLOG team is to look at, are you now talking about it? Is there MDT approach? What is your capacity? What do you have oxygen supplies? And are you planning ahead? How are you going to reduce to the risk for your infants to be infected with the RSV? Or if they do, how are you going to minimize any other, mortality or morbidity? And looking at your hospital length of stay, looking at who is actually qualifying to have the RSV, and are you identifying them? And what is your process to support those families? So what could be the challenges? These are things that we know that has been highlighted by various people from the discussions we've had. So there's the fear of the unknown, of what are we going to have? What is our locality? Because sometimes we don't even know how many children we've had last year, let alone try to plan how many children we're going to see this year. What could be the delays when they do come to A&E or our short stay wards? Do we have a dedicated team that was going to support when these children do come? Because A&E is already busy. So how is it going to be facilitated to make sure that they're not just going to be sitting around and waiting? Do we have information booklets? Are we empowering? We cannot be there every time. You might be the one championing the work, but how are you also empowering the rest of your colleagues on the ground to be able to support each other when you have 50% of more children coming into your services? How are you going to overcome that lack of knowledge? And how are you going to make sure that this RSV, you are coding it? I think one of the things you have to also be mindful as a clinician is actually just don't think about, okay, yes, I know the clinical side, but how are we going to identify how are we going to know how many are going to come in? Is there a clinical code within your system? Whatever system you're using, if it's Budgenet, if it's Medway, there's so many different systems. But whatever system you're going to use, how are you going to identify that these children are the number of children that are coming into our service because of RSV? So there will need to be a plan for that. Your clinical codes, your blue text, speaking to your pharmacist. So these are some of the challenges. So the planning, as we've highlighted, think about what's the guidance saying. The Green Book guidance, especially, we know that they're from 2015. We're hoping that they'll be updated. We know there was a meeting about a couple of weeks ago or months ago, was it June, early June, talking about RSV. But actually, part of the whole thing is we know that they need to be updated because the group of children that are in there has really expanded over the years, and that's not yet been included. And actually asking ourselves, do we have pathways? Yes, I know there's various pathways. I've been following on Twitter and different groups there's different pathways that are coming, managing children on bronchitis. But actually, I'm yet to see what's the pathway that people are doing to actually try and prevent more children coming in and needing to be hospitalized, needing to have that oxygen being sent home, because we need to think about prevention. The NHS long-term plan for 2019 was about talking a lot about prevention programs. We need to also think, how are we going to minimize and prevent all these challenges? Who's leading? And I've highlighted about, recording and talking, but we need to remember, we don't want to forget those parents, because they're going to be the one having to look after their baby if you do send them home with that child, and having to keep an eye on that child while they're waiting for their community nurses or go to their GP. So we need to really make sure that they're the center of the discussions we're having. So a few questions that we say, ask yourself, how will I convince people that there's a problem? How will I convince that we have a solution? How are we going to capture that data? How are we going to monitor the service and the process? What's the culture within your department? When I mean culture is, have we always thought, you know what, it's always worked well, why change things now? Maybe, we need to just do things in this way. So it's about changing those bits of safety cultures to just make sure that we put our patients at the center of that. How are we going to reward staff? Talking about rewarding, to me, it's about empowering, talking about saying that we value your contribution, because staff really appreciate when you can acknowledge that they are contributing as well. Securing what are the challenges if we don't go into the right way, if the plan that we think we need to do and we don't do it. The worst thing we can have is actually 2-3 months down the line and think, well, we should have just done what we thought we should have done earlier on. And I keep on highlighting about patient safety, because that is the driving force of everything that we do, every day. I just wanted to touch a bit on a survey we did in 2001 of the Northeast London, and that is when I was in the previous role. And we looked at actually RSV and what, the numbers of children. As you can see, so in 2014, the pathway was that we only managed to identify about 24 to 28 children to be immunized for RSV. However, by 2017, we were able to identify 78 children to be on that pathway of getting the RSV immunization between September and February. So I can imagine that was 2017. So from 2014, having 28 being identified to 78 or 74 to 78 being identified in 2017, I want you now to calculate how many this year will be identified. We should expect the numbers to be nearly 200, because that means we need to anticipate how is that number growing. How many children then are we expecting based on the modeling that we have? How many children are we missing as well? So as you see with the survey, we recruited, these were less than 2 years of age, 72, and some were twins, and 43 parents completed that survey between, and they all came to the clinic, which was run on the first Tuesday and first Friday of the month. And the feedback that we got, how were you informed that your baby required RSV immunization during the winter time? As you can see, we had a few informed during the ward round, a few was other, and a few was outpatients follow-up, and a numerous number said actually talking to their community nurses. And that already showed us the role of the community teams in actually informing and educating these parents that the children actually qualified to have an RSV immunization. So in summary, what we identified is there was an important role the nurses were playing in educating, that there was a booklet as well that was being given every time those nurses were going to start identifying the children that qualified for the RSV. Written consent was taken to make sure parents understood why their children needed the RSV immunization. And an audit was also done. And actually 2 infants were confirmed to have RSV bronchiolitis during that time. And that was actually before. So that immunization process minimized 72 children having to be hospitalized because of RSV. So that already gives us a bigger picture of the work that we need to do as health professions. So the key, designing your service, the child is at the center. Ensure that all children that are eligible for RSV immunization are vaccinated. Be transparent with parents. One of the things parents now we know, especially that we've got social media, they can go and search for things themselves. So if you do not tell them and you're not transparent with them, they will go on the internet, they will do their own research. And to me, that worries me because some of the things that are on the Google search are actually not always evidence-based and are actually not always research-based. As I said, people are coming up with their own minds and can publish anything depending if the journal wants to publish it. So if it's not a peer-reviewed journal, they can always publish and people can put blogs about things. So we need to ensure that we educate the parents early, give them that information and be transparent so that by the time they do their further research, they have the right information. As I've said, we need to reduce morbidity and mortality. Before we started in 2014, that RSV clinic in that area, 2 children unfortunately had died of RSV that had been on home oxygen, that had gone home, and actually there was no RSV clinics that had been started in that area. Now there's more RSV clinics. So we shouldn't, as much as I want to advocate that we definitely have to make sure there's oxygen, definitely need to have it. But we need to make sure this is the time we identify those children that are eligible for the RSV, even though they go home on oxygen, but actually we're minimizing them coming back in and out of hospital because of bronchiolitis. So recommendations, that's why I spoke earlier on about the code. Make sure that there is a code within your hospital. We are working with Moni and Caroline to make sure that we also, from a regional point of view in London and hopefully nationally, that there could be something put in place so that we also are able to have an oversight of how many children are also. So in your local areas, you start being the driving force. Is there a clinical code to identify these children that will qualify to have the RSV immunization, and those that are not qualifying but might come into your A&E, in your short stay wards, in your pediatric wards, or maybe they're already coming from the neonatal unit needing that oxygen because of RSV bronchiolitis. Identify them during the whole process. Have an MDT, a multidisciplinary approach that is diverse. You need your pharmacist on board to talk about blue tech. You need your commissioners on board. You need your health professions, your nurses, your consultants. Everybody needs to be on board. If you can, you need your parents to be on board to support you. That is the pathway actually feasible that you're trying to do. Because from learnings, children and, within neonate and pediatric, we are not very good at getting the parents' voice in our pathway development. We do consult them at the end, but actually when it comes to, did we actually do it with them? Did we co-produce? Did we co-design? We're not very good at doing that. It's something that is happening a lot within adult services, but actually within neonate and pediatric, it's something that we need to work a bit better on. Having that visible transformation leadership that is managing all this. People need to know what's happening. How are we going to do it? You need to be there. You need to support your team. People need to know who's the go-to person as you're starting planning any pathways, your oxygen pathways for RSV surge, your RSV immunization clinics, whatever pathway, people need to know who's the go-to team that is supporting a system approach. Everybody needs to be involved. You need to identify, you need to know your local area. To me, that's key. Who in your local area right now, do we actually know our population? Do we know which is the vulnerable group? Do we know that, do we have more children from this area? Maybe sometimes it's even a postcode that we know that children within this area are more likely to end up needing oxygen, are more likely to end up being hospitalized. Why is that? This is some of the work that you could be doing with your public health colleagues to actually find out. And we know that children from the most deprived areas are more likely to have poor outcomes. Do we know that? Have we tried to look into that? So it's important that we look at that information so that we know who our population might be. This is just some key information to read about that's highlighting. There was some work that we did with Alvi a few years about developing your nurse-led respiratory clinic. So that can help if you're trying to develop one. If you don't have one, we're going to be sending and sharing this links anyway. I always like to leave something at the end. So stop being afraid of what you could go wrong and start thinking of what can go right. We need to start planning. We are already in August, and I can bet you right now, most RSV clinic have not been set up. People are still waiting for something. I think I would be thinking we need to be having clinics starting either end of August or beginning of September, actually immunizing all our most risk. As soon as Blue Tech is opened, that's why I'm saying speak to your pharmacist. As soon as your Blue Tech is open, you need to put in those children that are eligible to have that vaccination. You need to speak to your community nurses. Identify if you start seeing those surge of children that are going to need that home oxygen, that have never been needing that home oxygen, if they qualify to have the RSV immunization, instead of just sending them home and just keeping them home with oxygen, what else could you do to prevent them coming? I've seen children that go home on oxygen, don't qualify at the beginning for the RSV immunization, and they come off the oxygen 1 week, 2 weeks later, they're back into A&E again. They require the oxygen again. And then they send them home. They feel better, they're fine. Again, another week, they come back. So do we want that pattern to happen throughout the whole winter? Or do we start trying to plan on how do we prevent more and more children? There is enough oxygen, as Caroline has reassured us, out there and money. But how many do we want to them to keep on coming in and out of hospital? What can we do to minimize as many of these children doing that? So thank you. I won't touch on the chat box now. I'll let Moni do a presentation, and then hopefully after that, we can do 1 or 2 questions. I'll hand over to Moni. I think you're on mute, Moni.
Thank you, Tendai. Thank you, Tendai, for inviting me to present a little bit about what my team does for the London Home Oxygen contract. My name is Moni Abiola Pella, and I'm the operational lead for the London Home Oxygen Service contract. I'm a pharmacist by background, and the London Home Oxygen Contract Management team is made up of 4 members of staff. So there's myself, there's my colleague Karen Davis, who's also a pharmacist by background and is the regional lead for the London Home Oxygen Service. And then we have a pharmacy technician and a support worker who also help with reviewing some of the invoices and some of the data that comes our way from Air Liquide. So today I just wanted to tell you a little bit about what my team does and how we can be of help to PLOG and just the pediatric home oxygen clinicians in general. So just to tell you a little bit about the roles and responsibilities of my roles and responsibilities and of my wider team. So our main role is to manage the contracts between the CCGs and Air Liquide, as Air Liquide are the designated home oxygen provider for all patients who require home oxygen in London. And what we do is that we contract, we monitor their contract performance against the service specification that we procured the contract against. So we link in very closely with Caroline and other members of Caroline's teams to make sure that the delivery of the service is as we've commissioned it. We also link in very closely, not specifically with the CCGs, but with healthcare professionals through clinical forums like ELCON and the SRG to also find out how they are perceiving, experiencing the service that's also being delivered by Air Liquide, and help feedback any issues that may arise or any compliments as well, or anything that, you know, the region feels like they would benefit from having changed or included within the contracts as well. So we have that open dialogue with Air Liquide. We're also, as I mentioned, we're pharmacists. Oh, sorry, Tenda, I'm still on the previous slide. As I mentioned, Karen and I are pharmacists by background, so we don't just come at managing the contracts with a commissioner and finance hat on. We also want to see clinical benefits and shape the clinical pathways that are actually used to use the home oxygen service. So we're members of the London Clinical Oxygen Network, and we work alongside, you know, Debbie Roots, Caroline Locke, Tendai as well, who's now joined us to represent the paediatric cohort to produce guidance for the London region. And by having this forum, we're able to not just, help produce guidance or policies, we're able to make sure it actually gets ratified by, recognised bodies or recognised forums within London, so that commissioners then can also support the implementation of the guidance that we put together as well. We also manage the HOOFB portal access. So as a lot of you will be aware, you have to register on the portal for HOOFB access, and you're required to do some level of training with Caroline Locke, or, if it's that you're in a team where you have a very experienced lead, with your lead as well. So we tend to manage the requests that come our way. We do that for some CCGs, we take that sole responsibility, whereas for other CCGs, we might link in with the HOSEAR lead to manage those requests. We also represent London at regional meetings. So we actually have a national home oxygen regional leads meeting where we represent the London voice, and we also represent London at the national patient safety meeting as well as in meetings with the fire and rescue services as well. And we just aim to bridge the gap between commissioners and clinical teams, because as I said, the CCGs commission the service from Air Liquide, but it's actually the clinical teams that actually deal with the service. They utilize the service the most for their patients. Next slide, please, Tendo. So in managing the home oxygen service contract, obviously we have come across a few issues in the paediatric landscape. And one of the big issues that we've come across is the lack of commissioned paediatric HOSEAR services. I know that a lot of community teams take it upon themselves out of goodwill to look after paediatric patients in the community, because we find that a lot of patients tend to be lost to follow up between being referred into a tertiary centre or secondary care and being discharged back to the community without a actual transfer of care pathway with specific details as to who's going to continue to monitor, review and make changes to the patient's home oxygen, as well as making sure that when the patient no longer needs it. So I think Tendai mentioned it, and in the presentation from the clinician at the start of the session, it's also about stopping the oxygen as well. So when patients need to exit the pathway, we need to make sure that there's a plan for that. So, neonates might get to the point where their lungs have developed so sufficiently that they no longer need it, but the oxygen tends to be left in their home because there's no pathway that says, okay, this is how you then exit the pathway. Parents don't know who to contact to get the oxygen removed. And that in itself is, that creates safety risk, because introducing oxygen into the home already is a risk. There's fire risk, there's trip risks, as well as it creates a cost to the NHS for, continuing to pay for the rental of equipment that's not actually being used, as well as keeping equipment that could be put back into circulation for other patients who might actually need that equipment as well. Another issue that we've come across is the fact that there are quite a lot of accounts without annual reviews. And I say they're without annual reviews with caution, because the way that I'm able to identify these patients is the fact that their HOOF hasn't been updated in the last year. So I then make the assumption that they haven't had an annual review. They might have had an annual review, but their HOOF wasn't updated. But for us to know that the patients had an annual review and that the clinician still deems that the equipment is clinically appropriate and safe to be in that patient's home, the HOOF needs to be updated so that we have that awareness. So I make the assumption when I say that there are accounts without annual reviews. And also, when accounts don't have annual reviews, there may be a missed opportunity to possibly wean the patient, to remove the oxygen if they're no longer needing it as well, and reduce the cost to the commissioners as well, and also increase the safety within that patient's environment. It might be that they don't need as many cylinders as more. So the less cylinders, obviously the reduced risk in the patient's home as well. Next slide, please, Tendo. I've included a few numbers here. So as at July this year, we had 834 paediatric HOS accounts across London. And of these accounts, you can see that more than half of these accounts have not had their HOOF updated in the last year. So their HOOF date is at least a year back from now, or even longer for some patients. We do have a small proportion of patients who have the HOOF dated prior to Air Liquide actually being the supplier for the London region. We also have some patients where the hoof has a variance, or the patient's holding has a variance to what's actually on their hoof. So they might have more or less equipment than what's stated on their hoof. Again, that could be a clinical risk if they haven't got enough, because they might be, trying to mise what they've got when actually they should actually have more oxygen. It's also a potential cost pressure as well, where the patient then has to keep requesting urgent orders if they haven't got enough, rather than having sufficient amount where they can get regular routine deliveries. And also, it could be a safety risk as well, where patients have much more cylinders than they should have. And the risk assessment that was possibly done in their home only accounted for the number that was on the hoof. So there tends to be a risk introduced there as well. We also have 143 patients who are in PEP. I'm not sure if all of you are aware of what PEP is, but that's the patient escalation process. And that's where patients who have oxygen concentrators haven't had their oxygen concentrator serviced within the time frame that they should have, or they have not allowed Air Liquide to come and do the routine risk assessment. And again, there's a risk with those patients because by not having their concentrator service, we don't know that it's actually delivering as it should be, that they're getting the right oxygen, the right amounts that they should be getting by using that concentrator. And by not having the risk assessment as well, Air Liquide are not able to identify if there are any concerns that might need clinical escalation or, safety escalations back to the clinician as well. And again, I've put ambulance equipment, but I meant to say ambulatory equipment. So of the pediatric patients with ambulatory equipment, we have 677 where their usage is less than 25% of the recommended usage on their hoof. Within the last year, obviously we've had COVID, so some of this might actually be due to patients shielding or not going out, or it might be due to patients not being at school as well. That might be why we've got so many. But there will be a proportion of those patients where they just actually don't need the ambulatory equipment. And again, that's an opportunity to reduce the risk, put equipment back into circulation, and reduce commissioner cost by making sure that those patients' equipment is reviewed and removed where it's no longer clinically required. Next slide, please, Tendo. So the support that my team can offer is obviously we can advocate for investment in pediatric HOSEAR services. So obviously I've mentioned some of the numbers in the previous slide, but it's not just the numbers, it's making a case of those numbers, the impacts, the clinical impacts, the safety impacts, the financial impacts, and using that as a service to create a case that we can support having that discussion with the commissioner to ask them to invest in the local teams and in local HOSEAR services in terms of staffing and possibly, helping source the right space for the clinics to take place in as well. We can support discussions with stakeholders on complex cases. Obviously, you are the experts in terms of the clinical, but sometimes you might need us to get in people from the CCG, from safeguarding. You might need support from the London Fire and Rescue Services as well, and we can facilitate some of those discussions as well. We can also support discussions with Air Liquide on any issues raised in terms of if there actually are any complaints or incidents that may have occurred, and also if it's a request to, implement change in some of what Air Liquide is doing. And if it's within the means of the contract, Air Liquide are very supportive and helpful and willing to make change that has benefit to the clinicians and the patients who use their service as well. And again, we provide input at a national level. So for instance, the IHORM is a national document. And for national change to happen, we obviously need local feedback, what's actually happening on the ground being fed back up to the national team. And we are the voice of the region in terms of taking that feedback back to national forums. And another thing that we can do as well is obviously support surge planning and RSV. I've put both because obviously prior to RSV, we were supporting with COVID planning, but now RSV is quite, it's here, it's important, as Tende said, and it's something we should be talking about and planning for, and we can support those discussions. Next slide, please. So in terms of RSV planning, I think Tendai has done a brilliant job in talking about everything that we should be considering. Tendai, Caroline and I have joined a few local meetings where they have had discussions on RSV planning. And do you know what? It's great to see that people are being proactive. with COVID, we had to be reactive and just act on our feet in responding to the oxygen demand and all of the demand that came with it. But with RSV, we've had, fair enough, it's not several months or half a year's notice, but we've had some notice that, you know, the season is expected early and the season is expected to see more patients. So it's great to see that proactive approach that people are taking. But I think one of the key things, as Tendai mentioned, is the MDT approach, engaging with the wider teams at the hospital and regional contracts. So through some other work that I do in supporting bulk oxygen for acute providers, there are people in the hospital who are also planning and talking about the oxygen demand through the piped oxygen system to the wards, and they're making plans. So it'll be a great thing if all of the plans could be joined up, if there are pathways from the point of the patient coming in using the bulk oxygen to the point of them possibly going home with using home oxygen. It would be great if all of that was actually brought together to make sure that there's consistency when, you know, we do need to utilize that, you know, that means that we've put together as well. I think it's very, very important that there's engagement with Air Liquide in particular, because if there is going to be an increase in discharges for RSV where they need to use home oxygen, it's important that Air Liquide know that there might be a potential increase in demand on their service, a potential increase in rapid discharges. And if there's going to be a particular modality that is going to be used, or a particular cylinder size that's going to be used, or even if it's a particular consumable that might be required for these patients, it's important that Air Liquide know that, so that they can potentially ring fence that equipment for the RSV season, or should they need to, you know, try and get some additional supplies to be able to fulfill the needs of the region as well. And again, Tendai has also mentioned about the pathways. It's about having, you know, the top to tail pathway, having the clear entry point into any RSV pathways that will include home oxygen, and having the end or exit point to that pathway as well. Yes, you know, for the hospitals to cope, it's rapidly, you know, seeing the patient, making sure they're stable and getting them home. But then they become an issue in the community where there isn't an actual clear pathway as to who's going to continue the ongoing review, monitoring, and most importantly, when they no longer need that oxygen, take that oxygen away from the patient. Because I think, you know, it's fair to say if a parent doesn't know any better, they can easily just discard of the equipment because they haven't been told otherwise that, you know, you actually need to return it back. It's not a parent might not know that the concentrator can be reused or the cylinder can be refilled. So it's important that there's a pathway that encompasses everything. When equipment is lost or not returned to Air Liquide, that's obviously a loss to Air Liquide, and that's also reflected in the costs that are charged back to the CCG, and so back to the NHS because of equipment that has been lost as well. And again, an important thing for me is also ensuring that there's competency for home oxygen prescribing for RSV. So as I said, we manage the HOOF-B request, and we've had an influx of HOOF-B requests for HOOF-B access requests for those wanting to prepare for RSV prescribing. And, you know, that's all good. Again, I encourage a proactive approach, but we also need to make sure that those that actually have the access are those that are familiar with actually using the HOOF-B and prescribing home oxygen. I know that Caroline has been offering a lot of support sessions or training sessions just to support those who actually are requesting for HOOF-B access specifically for RSV. So it's making sure that those that do have the access actually have the competency and the support that they need to make sure that prescribing is clinically appropriate and safe for those patients, making sure that risk assessments, very importantly, are completed. I think that might be on the agenda to be spoken about by somebody else, so I won't steal their thunder. I'll let them talk about that. But, you know, it is very important that risk assessments are completed. Next slide, please, Tendo. So, I mean, thank you very much for having me here and allowing me to talk to you about what I do. I've included my email address here and our team's generic email address. Should you have any questions about the contract management, about the HOOF access, or, you know, anything that you'd like us to raise with Air Liquide, then feel free to send us a message or send one to our generic mailbox. Thank you. Thank you, Tendai.
Thank you very much, Moni. That was really useful. I'm just going to try and pick one or two questions. Is Caroline or Debbie or Lynn are able to help me pick up one or two questions from your chat box? Let me have a look. So there's been a lot of chats regarding RSV. Yes, Caroline?
Hi, Tendai. It's Caroline here. I've picked up that there are a couple of people have asking about the annual review. So those who've got Part B portal access and actually has ticked the box for PID, you have a plethora of patient data and information available to you as a Part B user that you'll be able to manage your patients accordingly. So I think somebody was saying that perhaps Air Liquide can send a reminder just before the patient's due an annual review, but there is a huge amount of information. So anybody who would like to have some reporting portal training in London, I'm more than happy to pick that up. Thank you.
Thank you, Caroline. Yeah, Moni?
Yeah, I was just going to say as well, part of our team also send out emails to prescribers to remind them that they need to update patients' hoofs. Obviously, there's quite a lot of patients, so you might not get that every month, but we try to send emails out and send emails out to teams as well, where we know that there's a local HOSER, commissioned or non-commissioned, who look after patients.
Thank you. So if you're a prescriber, keep an eye on your emails for that. And Caroline has highlighted about the training. The training as well, she did one a couple of weeks ago. We recorded it. So that's also on our PPLOG YouTube channel. So you can actually, if she's on holiday and you really want to know, but she still needs to then make sure you understand and go through things with you so that she makes sure you're safe enough to be able to be put, because it then goes back, if I'm right, Moni, to your local CCG leads to actually sign off to say, yes, you can be accessing the portal to be able to order oxygen. So it's not just a matter of just doing the training, because we know that there's people that have just joined the training sometimes for 2 minutes and say, oh, now, I can just go in and just start ordering oxygen. You have to go through to make sure that you're safe enough, you understand exactly what's happening on the portal, you know how to do your reviews, and then you're able to be given that access. And picked up a few things as well before we move on about RSV as well. Thank you for those that have put in the chat box about some of you have already started in July. Well done. It's so exciting when you hear that things are already ahead of the game. There's also a Health Education England, yes, respiratory surge. They did a document which has been circulated. So we know that there's a couple of documents. Some people locally are also doing their own documents. So hopefully there will be something that's quite uniform. But that's great. Thank you for starting early and identifying your most vulnerable patients already and, following the national guidance. So I think we're so excited. I know there's a question regarding sickle cell is that about COVID or is that about RSV? Is that Caroline? I'm just trying to pick up. Was it, because she's got a few questions in there. Should we consider vaccination this cohort of patients? So you mean your sickle cell, and we follow the Green Book, directive of who should be vaccinated, because that also goes on the blue tech. So if the patients, and that will also depend on the clinician. So if those don't meet the guidance, there is a form that they can complete on the blue tech to say why should that patient be given the RSV vaccination, and that will then become a consultant decision. So and that child is 11 years old. So I would say, because they're quite above the age that is even given on the RSV groups, that would be needing to be the named consultant to actually have that discussion to say, what are you planning to do this year? So I cannot give you an accurate answer on that. So I would say speak to the named consultant, speak to your local pharmacy, and look at the blue tech and then see, is there a case for that? Sometimes it takes a bit longer because it needs to be discussed as a multidisciplinary team to say, why do you think that child would qualify, regardless that they don't meet the national guidance? So Thank you, everyone. Thank you, Caroline. So we were hoping to do a quick break. However, because of time, so I'm just going to say, if it's okay, just allow people to just go and stretch their legs, grab a cup of tea, 5 minutes. So 20 past 11, if you could be back. It just gives people an opportunity to stretch their legs, grab a drink. So in 20 past 11, please could you be back to join us? Thank you.